Hi, my name is Jack Magill. Very excited to be doing the second episode of Ask Me Anything for the knee SIG. A little bit about me. I'm the current faculty development resident in Duke's DPT program. Prior to that, I graduated PT school from Elon University, and shortly after graduation started working in the Duke health system, primarily at Duke Sports Medicine. While at sports, I participated in a manual fellowship that was led by my primary mentors, Mike Schmidt and Mike Raymond. While as a full-time clinician, I developed a practice with surgeon Jonathan Rebo, where I primarily was treating pediatric ACL reconstructions. From there, we developed a research agenda together that looked at how we determine readiness for return to sport and kind of efficacy of our treatments. That happens to be the topic of my slowly developing PhD at the University of Copenhagen. Just a word on perspective, by no means am I the absolute expert on anything spoken today. If anything, these are my opinions and what I've learned through my time treating pediatric ACLs. If this is an area that you find interesting, just for a plug, I would encourage you to check out the Pediatric Research and Sports Medicine Society, PRISM. They have an excellent conference that's coming up this winter where PTs, ATCs, MDs, DOs across the country come together and present and talk about current concepts in pediatric sports medicine. It's a great society. The president is Mark Paterno, a PT from Cincinnati Children's. So if you're interested, please check that out, as well as some of the content that myself and other people are putting together for CSM this year. So that's a plug to hear probably better people than myself on this topic. But that being said, I'm excited to answer some of these questions. So this is a question from Chris. Jack, you've always had interesting insights on the role of neural adaptations and neuromuscular reeducation in the pediatric population following ACLR. True strength returns from rehab are probably largely absent from a lack of circulating testosterone. Can you speak on this more and how this changes your exercise programming following ACLR? Thanks, Chris, especially for giving me the note that I have interesting insights. Should be known that Chris Lefevre, who's doing this, was a colleague of mine when he did his fellowship at Duke Sports a few years back. So an unnecessary compliment. We'll see if it plays out. Yes, pediatric patients have a different way of strengthening than the adults. The main theory is that they make strength through the utilization of motor unit activation. So basically, that's kind of the heart of pediatric rehabilitation, whether it's post-operative or even non-op, like with PFPS or another pathology. So with these groups, we focus a lot on neuromuscular reed. So that looks like NMES early and often, coming in doing a lot of NMES stuff. Just to get some more motor unit activation, maybe when they're still like plinthicizing on the plinth, or even when they're starting to get up and putting weight through their legs. Adding NMES is a great way to kind of increase those motor units. And there's a cat. Another thing that's showing promise is some of the BFR studies. What's interesting about BFR, we're in like the early days, but there are some studies that show in the pediatric population that using BFR is showing to have increase in strength. One study that we'll put the link here looked at doing high intensity versus low intensity in BFR, and found that in the BFR group, low intensity BFR group, they increased their 1 rep max with squatting. So this is early days of BFR literature, but still promising. And is that really much different than how we would train pediatric patients? Probably not. It's high reps, low intensity. So yes, those are pretty similar. I think the point, though, that we need to make is, even though that we are doing rehabilitation with the idea of motor unit activation and lower reps, or higher reps, lower weight, we still have to get to a point where we're working on power and we're working on rate of force development. So we still have to get to the point where that we're doing more traditional power training and jumping, right? It's just this is how we begin. And I still believe that power training is still effective if done correctly. I think the biggest hurdle, though, in this group is that we don't know a lot about dosing. Another study that looked at what is the actual efficacy of balance programs that would help with neuromuscular reed, they found that there's a large variance in terms of how much and how long we need to be doing in this population. It ranged from anywhere from 30 to 60 minutes a week was determined effective, up to two times a week, and in intersession anywhere from 4 to 15 minutes was also effective. So there's this large variance in this population, and that's kind of the story of pediatric sports rehabilitation. Is the data we have isn't the best, but we're just trying to build off of it. So in summary, yes, do NMES. BFR seems to be a viable way to increase strength as well. Balanced single leg strategies also well, with the goals of trying to get to power and rate of force strengthening at end rehab. This is another question from Chris. A pediatric ACLR certainly changes what occurs in the OR for our physician partners from a technical standpoint. However, broadly speaking, what does this change for us in the PT setting? What should PT students know about their first pediatric ACLR? Well, this is a big question, and just to speak broadly, I'll start with the cliche, but it's a cliche because it's true. They're not little adults, and that's important. They have the same goals of adults. They want to get back to what they were doing before, but they will get back at a higher rate than adults. But they also have a higher re-tear rate than adults. So the first thing to know is you have to be deliberate and you have to be intentional with them. You have to be deliberate in determining when it's safe for them to go back, and that's going to be a collaborative process with the athlete, with the parents, with the physician, in determining when everyone feels good about it. So I think a lot of the other questions that were asked kind of talk about the differences, but this population is exciting. They make you feel good because they're motivated. They inherently do well, but it is our responsibility to make sure, like I said, that we are deliberate and intentional with their safety in returning to sport. For PT students, what else you should know is that this is just a great population. It makes you feel good, and it makes you want to keep coming back to the clinic because of how fun of a group they are in. So enjoy working with them. I certainly do, and I plan on working on them for the rest of my career. This is a question from Chris. In contrast to my last question, speaking more specifically, does the pediatric surgical technique used have specific implications on rehabilitation? Extraphyseal, epiphyseal, or transphyseal? It's a good question. Shameless plug. CSM this year, Laura Schmidt, Matt Ethelburn, Mark Paterno, and myself are giving a talk on rehabilitation techniques based on rehabilitation considerations based on graft selection. So if you're interested, please come check that out. It will be much more eloquent than what I'm going to say here. So I'm excited for that talk. But to answer your question, yes, there are generally it's going to be different. An extraphyseal, or the IT band or Magill procedure, doesn't require any drilling or screws to be performed. It's non-anatomical, starts from the outside of the joint, moves to the inside, comes back to the outside, doesn't hit the growth plates. Typically, because it's the way it's performed, there is a period where the patient is in non-weight bearing, or they have precautions on weight bearing. So if we think about the previous question about motor unit activation and strength gains, we have to consider how are we going to try and increase motor unit activation with non-weight bearing. So those patients might be seen more frequently or given at-home NMES units like a Nehab, or performing BFR at home, or etc. Besides that, the other implications would be if these are revisions or revision surgeries. In general, revisions like the adult population are going to be slower. The strength gains are going to be harder to come by. It's going to just take longer. All in all, they aren't very different. The physiology of a pediatric patient is going to be the primary driver of the rehab, not necessarily the type of surgery. However, the type of surgery will also be led by the demands of the patient. So that might go with doing a BTB versus a quad tendon in terms of like demand of sport, whether they're a catcher or a dancer that requires kneeling, and that can play into it. But all in all, not a whole lot of differences based by the surgery, notwithstanding the weight bearing. This is a question from Beth. Can you speak to the literature on IT band autograft in skeletally immature? Anecdotally, they put on strength very fast but have high retear rates. Should we be trying to turn these kids short-term or potentially long-term into copers and delay surgery until growth plates are closed? So this is a big question, and I think we'll start first with the retear rates. So in this population, if you do combined risk of subsequent ACL retear of ipsilateral graft or contralateral ACL, the risk of a secondary injury is as high as 30%. So it's a group that tears a lot. There was a period of time where the thought was, let's wait till they're skeletally mature, and then we'll do a traditional transphyseal surgery. Studies like Anderson, that was published in AGSM in 2012, looked at what happened if we delayed. And they found that by delaying surgery, there was an increase in incidence of both medial and lateral meniscal tears, and in both severity and incidence. There was also an increase in chondral injuries in both severity and incidence. So if we delaying surgery caused concomitant injuries. Another study that was published at AGSM in 2014 out of Dallas Children's found that waiting greater than 150 days was also a positive predictor of a medial meniscal tear and chondral injuries. So not only are they getting these concomitant injuries by delaying surgery, but they also have a very short window in which we can have surgical intervention without them. So I think that goes to the point of this is a group that probably needs to have surgical intervention, and that they won't do as well as a coper as the adults would. So then in terms of IT band autograft, it's been done for a while, but I think the incidence in which it's being done is increasing. So the data is starting to come out, and a lot of it's actually pretty good. Min Coker put out a paper that found that its retear rate was only about 4.5% by doing the IT band surgery. So I think the efficacy, there's clearly efficacy for it. It's a group that needs to have surgery. So if they have a lot of growth, this is probably a growth left in their physes. This is probably a good option for them. This is a question from Laura. What might you change, if anything, for return to play testing in a very young post-ACL, say under 13-year-old patient? And what would you use for normative data? Laura, this is a great question and a tough question. It kind of gets to the heart of the efficacy of our return to sport testing in this population. So the IOC released a consensus statement a couple of years ago, and they pretty much stated that isokinetic and hop testing has large measurement errors in this population. Also, tests that look at quality of movement have not been validated in this population. And overall, most protocols for return to sport are based on the skeletally mature and just applied to the pediatric population. So there's that. So what would I change? I think what I would change is what you asked at the end. Would I use normative data? If I had normative data, I would use it. And I think that's important for a number of reasons. One, if you tear your ACL and you're age 13, and it takes 9 to 12 months for you to return to sport, and you're now 14 or 15 years old, and we're comparing just a limb symmetry index, we might not know if you are where you should be in terms of a 15-year-old, or if you're just symmetrical and you're falling somewhere in between when you got hurt and when you got better. So that's the first thing. It would be great if we had normative data. We don't, and we have to do the best that we can. So I think limb symmetry, for all its faults, is a tool that we have. And I think that's the first tool that we use, is being symmetrical. Second, I think we apply what Elizabeth Wellstat found in her JOSPT article that was looking at the estimated pre-injury capacity, or EPIC. Basically, what they did is they measured a patient's isokinetics and hop testing on the non-operative leg before surgery, and they used that as a measure to determine return to sport. And they found that measurement, EPIC, was more sensitive of returning to sport without subsequent injury than just using limb symmetry alone. So if I had everything I could, I would say it's a continuum of first milestone, limb symmetry, second milestone, EPIC, third milestone, normative data based on age and potentially gender. The nature of normative studies is the biggest limitation, because to do them we need an enormous N to get beautiful growth curves that say you're male 13, this is where you would be to be in the 15th percentile of norm data. So that's going to take time to acquire and to do. And then it's going to take more studies to determine what's the number that's safe to return. Do you need to be in the 50th percentile by age and gender? Or do you need to be in the 75th or 90th percentile to return to have a decreased chance of subsequent injury? So I think if I could change something, it would be that. But I think we're a long ways out. But the long and the short of it is, I think based on the data, we have to use time. We know that 9 months is an important date, probably 12 months is even better. We use what we have in limb symmetry, EPIC, and then we need a strength measure. So we need to find out what we need for isokinetics. Is it asymmetry? Is it a percent body weight for these populations? We don't know. Does that change from being a 13-year-old to an 18-year-old? We don't know. So there's a lot of work that we need to do. But I do think that there's a lot of great researchers out there doing the work and figuring out how we can determine efficacy for return to sport. So, yes, I'd hate to end on a we don't know note, but we don't know. But we'll see if we can get better. This is a question from Marco. What are your thoughts on allografts on athletes under the age of 18? I've seen a couple recently, and they did not have any additional damage in which an allograft may have been indicated. Their response on why they chose the allograft was that there would be less pain. Okay, yes, allografts, typically have less pain. In an adult population, their rehab can be a little faster, but in the pediatric population, it's very different. So some research from the Moon group found that there are two factors that influenced re-tear rates. One was every year that a person aged, there was a decrease in rupture. Not a huge number, but a decrease. Secondly, allografts in the younger population had a 5 times greater re-tear rate than a BTB. So here at Duke, allografts are not used in the pediatric population, just for those reasons. The larger re-tear rate in general is a big one. So I've said that I have not seen a primary reconstruction of an allograft. I have treated patients who had revisions where their first graft was an allograft. At this point, I wouldn't say the literature is very promising on a primary allograft in the pediatric population.